Early non-small cell lung cancer. In recent years, there has been an increase in detection of the early non-small cell lung cancer, although tobacco smoke is the most well-known risk factor for the lung cancer. A magnitude of other environmental exposure and genetic factor can increase the susceptibility and development of non-small cell lung cancer. The mainstay of therapy for early lung cancer is surgical resection. The Cancer Network guidelines recommend contrast CT scan for the chest, abdomen through the adrenal, followed by a PET CT scan and the biopsy-proven suspected early-stage non-small cell cancer. Mediastinal lymph node greater than 1 centimeter in short axis, or those which demonstrate hypermetabolic activity on PET, are considered abnormal and warrant further evaluation, and routine pathologic assessment of mediastinal lymph node is optional for the primary solid tumor of greater than 1 centimeter and purely non-solid tumor of less than 3 centimeters. Primary modalities for mediastinal staging include mediastinoscopy, which allows access of mediastinal lymph node stations, endobronchial ultrasound, fine needle aspiration, and that allows access to station 1, 2, 3, 4, 7, 10, and 11, and endoscopic ultrasound, fine needle aspiration that allows access to the station 2, 4, 7, and 8, and 9. Mediastinoscopy and EBUS FNA have comparable sensitivity and specificity and diagnostic accuracy when performed by an experienced clinician. The adrenal masses detect the CT may have additional workup if the PET demonstrate elevated SUV max and the nodule exhibits above normal radiographic density. Adrenal biopsy is indicated due to the greater likelihood of adrenal metastasis. Brain MRI may be considered for patients with surgical 1B disease and is a requisite part for the workup of the stage 2 and above. Patient with suspected but not biopsy proven non-small cell lung cancer based on the clinical radiographic analysis should undergo a wedge resection, core-needle biopsy, or definitive diagnosis prior to proceeding with the definitive anatomic lobectomy. Lobectomy is established gold standard for resection for prospective multi-institutional randomized trial comparing lobectomy with sublobar resection for stage 1 non-small cell lung cancer, published by the Lung Cancer Study Group. This trial demonstrated a survival benefit of lobectomy as well as decreased rate of local recurrence. Although lobectomy remains the standard, some recent studies suggested that sublobar resection may yield adequate oncological outcomes for selected patients with small tumors with no clinical evidence of metastasis. A large multi-institutional randomized trial is underway to elucidate whether sublobar resection is a viable oncologic option for small early cancers. Early results of which demonstrate no difference in perioperative morbidity and mortality among the two groups. However, the oncologic outcomes are still pending. Patients with comorbidities precluding the standard lobar resection should still be considered for segmentectomy or wedge resection or on the surgical therapy. A sublobar resection with margins equal to the greater than the primary tumor may be a reasonable alternative for patients who are no lobectomy candidates because of the poor cardiopulmonary fitness or other comorbidities for the patient with the clinical stage, a disease who cannot tolerate, and the surgical resection stereotactic body RT SBTR is a potential alternative therapeutic approach. A sleeve of bronchoplastic resection is preferred for pneumonectomy. For centrally located tumors with a margin negative resection can be achieved. The optimal sleeve anastomosis is characterized by A well-approximated tension-free repair. The anastomosis should be wrapped with additional tissue for buttressing the suture line, such as intercostal muscle, latissimus dorsi, omentum, or pericardium. The buttress improves the healing and decreases the risk of fistula formation or breakdown of the bronchial stump, especially in the patient who receive the adjuvant therapy. For patients with the clinical stage 1 and 2, non-small cell lung cancer, lymph node sampling, resection, the time of the surgical resection necessary for accurate pathological staging. The 2020 NCC guidelines recommend sampling of N1 and N2 nodes, and it is additionally recommended that N2 lymph nodes be sampled from at least 3 separate situations for adequate nodal assessment. Surgical resection can be accomplished via the open thoracotomy and minimally invasive approach of VATS or robotic. The recent meta-analysis support the lower morbidity and improved quality of life and improved survival with the VATS lobectomy compared with the thoracotomy approach. The postoperative complications occurs approximately 30% of the patient undergoing pulmonary resection, and common complications include arrhythmias, prolonged air leak, pneumonia, respiratory failure, wound infection, and pain. The European Respiratory Society guidelines published uh, uh, discontinuation of the bronchoalveolar carcinoma. So, bronchoalveolar carcinoma, previously referred to as 5 disparate tumor categories with varying prognostic values and molecular properties. The lipidic predominant adenocarcinoma is a more favorable prognosis than other histological subtypes of invasive adenocarcinoma, and a multifocal AIS-MIA may be treated with several wedge resections in burden of the disease is not significant. All primary tumor biopsy specimens should undergo pathologic review to ascertain the histological subtypes, to assess the molecular targets that may guide the adjuvant therapy, PDL1, ALK, ROS1, BRAF, MET, and EGFR. Based on the current NCC guidelines, patients with stage 1A disease who undergo R0 resection do not require adjuvant therapy. The patient with stage 1 or 2 non-small cell lung cancer who undergo R1 resection should undergo re-resection preferred or the adjuvant radiation therapy. Chemotherapy is indicated in selected patients with a high-risk stage 1B or 2 tumors. First-line chemotherapy is cisplatin-based. For the patient who are unable to tolerate cisplatin, carboplatin combined with Plexatil is a reasonable alternative. Patients who are deemed inoperable due to lack of sufficient cardiopulmonary reserve to tolerate the pulmonary resection are treated with a definitive radiation therapy. SBRT involves a high-dose radiation conferred to multiple convergent beams focused on the discrete target. The benefit of SBRT is a rapid drop of radiation dose at the edge of the target, and which reduces the clinically significant radiation to the surrounding healthy tissue. The radiofrequency ablation is a potential alternative. Based on the current guidelines, the patient should be followed by a routine history and physical examination in conjunction with the chest CT scan every 6 months for the first 2 to 3 years following the resection, and annually thereafter. The new researches will better clarify the optimal surveillance for the patient after resection with secondary outcome. PET is not indicated for routine follow-up. Non-small cell lung cancer survivors should continue to undergo routine health maintenance. Thank you.